So hi, I'm Judy Chang. Previously, I was with the International Network of People Who Use Drugs. I'm now a program manager with Open Society Foundations, and really pleased to be chairing this panel today with a wonderful set of panelists. It's a topic that's very close to my heart, having been impacted very positively by harm reduction throughout the course of my life. I know intimately and personally how important it is to have gender responsive harm reduction strategies, and know how when they're poorly conceived or designed, that they don't reach and engage and actually push away the people that they're supposed to be serving. So in terms, throughout the course of this session, the question that we'll be asking and the panelists will be answering, we'll be looking at how do we empower individuals, women, trans and gender diverse people who use drugs to act to improve on their health and as a community. So in terms of panelists, we have Elivanda, Canuto de Sousa, Luca Stevenson, and he'll be presenting along with Rose Macalina. Instead of Emily Rowe, who couldn't make it, we have Joelle Puccio joining us, our Roig, and Wangari Kimemia. So we have between 10 to 15 minutes per presenter, and then at the end we'll probably have around 20 to 30 minutes for Q&A. So throughout the panel, just hold on to your questions and we will get to them by the end of the session. So first, I'm really pleased to introduce Elivanda. She was raised in the Favela of Mare. She's a harm reduction specialist and began her career in 2014 at CAPS 83, which is a public mental health facility, and she also currently coordinates a drop-in and harm reduction center in Mare, Rio de Janeiro. So welcome, Elivanda, you have the stage.
Buenos dias a todos, todas e todas. É um grande honor estar aqui, trazendo as vozes das mulheres de Maré, mulheres negras, mulheres de las favelas, mulheres de las calles, que resistem e reinventam a vida todos os dias, apesar de las violências. Meu nome é Elivanda, abro em nome de Redes da Maré e de Espaço Normal, um centro de referência em redução de danos na favela da Maré, em Rio de Janeiro, onde vivem mais de 140 mil pessoas. Aí quero compartilhar com vocês as experiências de nossas investigação e ação. Investigação e ação. Elas ensinam. Que nasceu de urgência a ser visíveis as histórias de mulheres cis e trans em situações de cargas e uso de drogas em nossos territórios. Pero mais que isso, quero ressaltar que raça, gênero e territórios não são só temas de projeto, sois eles que atravessam todas as ações de espaço normal. Primeiro, entendemos o território. A Maré é majoritariamente negra, feminina e marcada por o abandono do Estado. Mais de 62% da população se declara negra ou mestiça. As mulheres delas são maioria e levam sobre seus corpos de solo a pobreza e o racismo, sino também as marcas da violência institucional e de gênero. O que aprendemos com elas ensinam? Que a violência de gênero em la favela é intencional, atravessa da raça o território, o consumo de droga, a falta de políticas públicas, os estigmas e a violência institucional. Que as mulheres em situação de carga sofrem múltiplas violências violências domésticas, violência de las operações policiais, discriminações em serviços públicos. Que las ausências de políticas específicas para mulheres de las favelas generam um ciclo de abandono, silenciamento e enfermidade. Que resistir para ela é um acto diário. E que hacemos em espaço normal? Desde o princípio, entendemos que a redução de danos sabe ser feminista, interseccional e baseada em território. Cremos práticas que respeitam as histórias e o ritmo de cada mulher. Organizamos um dia exclusivo para elas, um espaço seguro, onde pode cuidar de seu corpo, de sua autoestima e construir redes de apoio. Oferecemos mais que serviços, oferecemos escutas, reconhecimento e acolhida. O cuidado começa em um gesto mais sencillo, em um banho caliente, em uma palavra de afeto, e uma mirada que disse, tu importa. Sabemos que as favelas, as barreiras para aceder à saúde e à proteção e à justiça são muitas, e que são maiores para mulheres negras, trans, usuárias de drogas e em situações de calle. Por isso, nosso trabalho é ter redes de cuidado e afirmar dignidade e construir autonomias. Aprendemos que a autonomia se constrói em coletivo. O cuidado é político. Redução de danos é abrir novas possibilidades de vida. Enfrentar a violência de gênero em maré é também enfrentar o racismo estrutural de las necropolíticas e o abandono que tenta negar a vida de las periferias. Para encerrar, as mulheres que resistem em maré nos ensinam a ter redes de cuidados, possíveis, incluso em meio do abandono. Que cada gesto de afeto, cada prática de cuidado, cada espaço de escuta é uma forma de resistência. Que significa juntas, em las favelas, em las calles, em los espaços políticos, defendemos as vidas de las mulheres negras e de las mulheres de las periferias e mulheres de las calles. Porque nuestras vidas vale muito que qualquer política, exclusão ou controle. Muitas graças.
Thank you so much, Elivanda. So just next we have two speakers. So first, Luca Stevenson, who is a sex worker and sex worker rights activist with 20 years of experience in community building, policy and advocacy for sex workers and marginalized communities. He's the new global lead on community engagement and partnerships at IPPF. And joining him is the wonderful Rose Marcalina, who is the founder and director of SPIN, also known as Women's Voice. Women's Voice focuses on advocacy and services for women and trans women who use drugs in Indonesia. She's also on the board of the international, I think newly formed International Network of Formerly Incarcerated Women, and is also a paralegal expert. I'll pass over the microphone to Rosemary as well.
Hello, everyone. Oh, it's really loud, no? Hello, everyone. Nice to see you all, and it's really exciting that there are so many people attending our session. It shows how important this topic is. Thank you, Judy, for the introduction. So, unfortunately, we were supposed to have a session as... It's too loud? Oh my God. We were meant to have a session with IPPF, but many of our speakers couldn't join. So that's unfortunate, and we want to send our love to the community members who could not attend. So we're going to share the session with Rosma. Judy was saying, I'm a sex worker, I was a sex worker, and I'm a sex worker activist for many years now. I'm on the board of the Global Network of Sex Work Projects. I'm also head of mission for the Jasmine project of Médecins du Monde. And I joined IPPF last year as the first global lead on community engagement and partnerships. And I wanted to just have a show of hands of who know who IPPF is or which IPPF member in their country is. International Planned Parenthood Federation. Okay, this is quite interesting to me to see that actually from this panel on harm reduction for women, very few people actually know of IPPF and the work that IPPF is doing. So, oh, yes, that's it. This, thank you. So, IPPF is a global healthcare provider. We are one of the main providers of reproductive and sexual health services. In 2023, we provided 222 million sexual and reproductive health services and contributed to 115 policy and legal changes in support of sexual and reproductive health and rights. We have 150 member associations and collaborative partners in over 146 countries. My background is working with community-led organizations. I started an organization in the UK called Sex Worker Advocacy and Resistance Movement. We did activism with no funding for years, like many community activists are doing. I was then the director of the European network, where we always struggled to even manage to keep staff. We never had an office. We always did like very grassroots work while trying to do policy work at the same time. So for me, it's been a huge shift to move from community-led organization to IPPF. But I think it's very important that big organizations like IPPF start to engage and hire and work with community people, community members who know what it's like to work on the ground with no funding and no support and facing so much attacks and criminalization. So it's a call out for any organization to do this work, to work with communities and engage communities. So IPPF has a new global strategy which aims to center marginalized communities. They recently announced a strong consortium with sex workers organizations with various countries. And they're also working very closely with trans communities, for example, in different countries and as well as the global level. However, when I joined IPPF, we say, okay, we have to come to the harm reduction, we have to liaise with the communities to talk about this topic. And I asked my colleagues who in our federation is currently working on harm reduction. And I'm just going to give you a very brief overview of some of the work we are doing, and then I will pass the mic to Rosma, who can tell you an example of strong partnership between IPPF member association in Indonesia and women who use drugs. Pressing on my computer is not doing anything. So one good example is the regional collective of women who use drugs. This is hosted by our South Asian office, which is in Delhi, and represents all the different countries in South Asia, India, Bangladesh, etc., Sri Lanka. This is a new network supported and led by women who use drugs. So Nandini was supposed to be here, but unfortunately she is not. So I encourage you to follow and find information about the work they are doing. They are organizing regional meetings to look at the issue that women who use drugs are facing, building community, doing advocacy. And going more at national levels, these are just a few examples. I won't go into the details. I invite you to reach out to member associations working in your countries. And if they are not yet working on harm reduction, ask them why. Ask the member association of IPPF, why are you not working with some of the most marginalized communities? So yesterday we had an amazing panel on reproductive health and rights and drug use. And our member association at IPPF needs to be working more on this topic. So these are just 3-4 of our organization. Sierra Leone, our member also offers short-term family planning commodities for women who use drugs, as well as psychosocial support and counseling. In Liberia, there is a project with our member there using music and art to build capacities of people who use drugs. In Sri Lanka, there is a strong partnership with Mituru movement through the global fund between our member FPA Sri Lanka also supporting women use drugs and people use drugs generally, I think. But I wanted to just give the mic to Rosma, who can give more in depth about the work and the partnership between IPPF Indonesia and her organization. And I really encourage you to come and talk to us, to me, to other people from IPPF, to really try to build partnership between more SRHR organization and women use drugs. So come talk to me after if you can. Thank you.
Hello, everyone. Good morning. I'm a little bit nervous. I want to talk about rapid situation and need assessment, improving sexual and reproductive health service for women and gender diverse people who using drugs from Suara Perempuan Lingkar Nafsa Nusantara Foundation. The background, it's the right of reproductive health is fundamental human right, and women and gender diverse people who using drugs face barrier to access. Stigma and discrimination, of course, remain high in the health service. There is still need identify need and gap, including inclusive and responsive service. So I want to tell why we make this assessment, because we have partnership with IPPF since 2024. We have make some workshop, focus group discussion with women and trans women who using drugs, with background sex worker, housewife, and other things. And then we find some story that in the last 2 years, so many trans women who using drugs pass away because they didn't have any information and education about drugs. So they use drugs, and then after that, they use injection hormone, and after that, they pass away. And the number is so highly in Indonesia. So model for collaboration, it's community lead and mainstream organization, co-equal partnership. Partnership and contribution for each means community lead, outreach, trust, thyroid, SRHR, and harm reduction advocacy. And also we have IPPA, long-standing HRHR provider, clinical infrastructure integration. So for this need assessment, we including the community lead outreach, and then also for clinical mobile clinic, we including IPPA for making mobile clinic. I'm a little bit nervous, sorry. Okay. Research model method respondent. It's location method is online. We doing online survey. Before that, we collect the respondent. We give some information, education, and then after that, we ask them to fill the online survey. After that, we collect around 10 persons. 5 from women who using drug, and 5 is from trans women who using drug, to do FGD, to collect more data and information. This respondent, 19 respondent, women and gender diverse who use drug. The location is in Jakarta, Bogor, Depok, and Bekasi. It's in the greater Jakarta. Next. The objective of this need assessment to having the latest information on socio-demographic and substance use behavior and risky sexual behavior and access to reproductive health service. This for socio-demography is really needed to see how related the need of women, especially for women who using drug, to access the reproductive health service. So majority age is 31 until 40 years old, and education background, most of them are high school graduated. And for the work background, for women, mostly it's NGO worker, housewife, and sex worker. And then for trans women, background work is they are sex worker also, some is entrepreneur, and mostly NGO workers. Substance use behaviors, substance use in the past week high, 10% from 1990 respondent, 10% use daily, and some have experience with overdose, and injecting drugs use minority but still present. So now situation in Indonesia, because heroin is no more in my country, so they use buprenorphine and also meth for injection drug use. And then for risky sexual behavior, 90% sexual active in the last 3 months, because if we see the 1990 respondent, it's mostly is sex worker. And high risk behavior in trans women. There's a high risk behavior in trans women. Condom consistency is high in the trans women group. So this is quite good, because a lot of trans women in Indonesia, especially in Greater Jakarta, they have consentence to use condom, but it's hard to find a women sex worker to do that. Next. Access to reproductive health services, it's very limited, especially for those without health insurance. So there is a lack of need for them to access the reproductive health services, because they very limited, especially without having a health insurance, national health insurance, it's needed. But to take the national health insurance, you have to take the ID, the national ID. And it's really hard to get the national ID, especially for trans women and also sex worker and people who using drugs, well, especially for those who just released from the prisons. And then the barrier is to access the reproductive health services. It's time, cost, distance, and stigma. So many people in our community still facing stigma and discrimination from the health district office staff when they access the sexual reproductive health services. For example, for sex workers, I'm sorry everyone. So when you access, for example, for like HIV test, and what is your work? I'm sex worker. How can you become a sex worker? You can find another job. And then that's why some people don't want to, only small number of people regularly access services. So it's only it's find it in this assessment result. Next. For FGD result, quote from the respondent, there is a quote from respondents. Services are there, but we are often locked down often. This is from FGD participant Depok, and from trans women in Bekasi, we need mental health services because we don't know to talk with. So it's hard to get mental health services with the national insurance because it's not covered. If you want to take the like psychology, you have to pay the money. Next. The specific need is we need pap smear, anescopy, hormonal therapy, because it's hard to find services, good services, especially for trans women who using drug to access hormonal therapy, because it's not allowed for trans women. Hormonal, it's only allowed for women. Then for counseling, there's also specific need for counseling, counseling about reproductive health, mental health, and addiction. For us, as a woman who using drug, when we are pregnant and we go to the doctor, and we want to telling about our addiction, related our addiction to our pregnancy. the doctor sending us to National Narcotic Board, and then we got treatment. We don't want that. We just want to access the real how the effect of our drug use to my baby, only that, nothing else. But we still worries we will arrest by the police because we are still using drugs, something like that. So it's still limited access to get information related our pregnancy with drug use. And then gender-friendly and stigma-free services, it's very needed. The key finding is restrict access, high and very high discrimination. Substance use and sexual risk behavior are strongly linked, and there are specific needs that have not been fulfilled. Next. Conclusion, service strengthening, health worker training, and mobile clinic. We have policy advocacy, affirmation of reproductive health rights, and increasing public awareness. We are doing this. We using social media to increasing public awareness about our right. It's so funny if human right is our right. So what for we have to catch our right? It should be it's our right. Why we have to catch this? Next. So the next I can read it. Maybe I can read in this. Wait. Acknowledge and call to action. The work I presenting today wouldn't have been possible without the generosity and commitment of our funder. Their belief in the important and addressing the HR need of women and gender diverse people who using drug use has been absolutely instrumental. These funders have not only provided the financial resource, but also trust our vision and approach, enabling us to build platform to advocacy and change. Spin, deepest gratitude to International Planned Parenthood Federation, our IPPF, Opportunity Fund of Response Project, Indonesia Planned Parenthood Association, or IPPA, community parent and support, whose contribution continue to make transformative difference in the life of many. The work is collective effort. We need more backing, truly embed this service into our national system. Thank you.
Thank you so much, both. Luca actually was not aware that you were the first global lead on community engagement at IPPF, so breaking barriers, breaking ceilings there. And it's really great to hear about how IPPF are elevating programming for sex workers and women, trans and gender diverse people who use drugs. Rosmer, incredible to see the peer-led research there. Congratulations on that. And yeah, just seeing, a lot of the problems that you highlighted, very common the world over. But I think it was also important, to have you highlight that not only is it important to have right of access to health, but that it should be non-coercive and rights respecting. So next we're we're zooming out to a bit of a global we're zooming out to a global lens. So we have Joelle Puccio from Women Harm Reduction International Network. Joelle is a registered nurse with over 20 years of experience and a person who uses criminalized drugs. They are a co-founder of the Academy of Perinatal Harm Reduction and became passionate about advocating for people who use drugs after realizing that everything they'd been taught about drugs from childhood through nursing school was wrong. Thanks, Joelle.
Thank you so much, Judy. Hello, everybody. So as Judy said, I am representing RIN today, Women in Harm Reduction International Network. And our goal is really to provide a platform and a space for women and gender diverse people all over the world to get together and improve gender responsive services. And a big part of that is just advocating for the removal of punitive obstacles to health. When this abstract was accepted, the elephant that you're about to see had not yet rampaged into the room. This presentation is kind of just it's smushed together a bunch of different things. Emily submitted the abstract, Ruth made the slides, and I'm giving the presentation, so it'll be fun. So here's the elephant. I don't know if you can guess who the elephant is supposed to represent based on the toupee there. For those unfamiliar with English, the elephant in the room is a saying that we have that means something that everyone can see and everyone is aware of, but nobody's talking about. So imagine if there was an elephant over there and I was just acting like everything was normal. That's kind of what the elephant in the room metaphor means. So in order to leverage UN directives about services for women who use drugs, we intend to document what exists in order to, set a baseline that we can improve upon with this global mapping project. It was also created with the goal to uplift our successes and our solutions that are being, created and invented and refined all over the world, and so that we can replicate them in other places. We aim to highlight examples of good programs that work and also gaps both in types of services and in geographic locations. It has become even more important now in the context of all these funding cuts. So let's see, I think we talked about that. Not yet, sorry. Our goal was also to create a reference point for advocates to go to and look at what is happening in other parts of the world. What can I use? What can I pull from this report in order to replicate in my own location? And even before all these funding cuts were happening, we were seeing attacks on gender responsive services. This is not new. It's only ramped up since the attacks. Next. You can go to the next one. Thank you. So last year, we conducted a short anonymous global survey. This is the second time we've done this. We started the first one in 2021. And like I said, our aim was to identify existing services that are specifically tailored for women and gender diverse people who use drugs. We engaged 8 focal points in the community. I was the one for North America, which, due to language reasons, we just included the United States and Canada, and Mexico was included with Central and South America. We translated the survey into Arabic, French, Russian, Spanish, and Ukrainian. And the focal points reached out to folks that they knew of in their areas and tried to get as much information as possible from various stakeholders and attempt to document as many of the services as possible. We were specifically looking for services that were tailored to women and gender diverse people. So we're not looking for, yes, we have this service and women are allowed to access it. We were specifically looking for stuff for our people. We also included sex worker services, gender-based violence services, and specific sexual and reproductive health services, specifically for women, trans men, gender diverse folks in general. We also drew on qualitative data from community consultations, and we intend for this global mapping report to be a living document, especially now, since shortly after we released it, all of these changes happened and so many services have been shut down. The limitations to this approach are many. One of them is relying primarily on our allyship and people who are already involved in RIN. And in some cases, we had a lot of trouble identifying any contact in certain countries or certain areas. Another limitation is that it was only translated into, 6 languages, which is really not representative of the whole world. So we can't describe this report as exhaustive, but as far as we know, it is the only one and the most robust one that exists in the world. Next slide. So this is the cover of the report, And the eye represents the application of a gender lens. And then within the eye, you see a feminine presenting figure sitting under a fruit tree. The fruit tree has only one piece of fruit, and it is way out of reach. So that's kind of a metaphor for the way that gender diverse services are presented. Our 2024 findings, unfortunately, only showed a modest increase in services from the 2021 mapping. There are just very few services directed at us. We're expected to just access the services that are designed for the most part by and for men, and we are expected to adapt rather than having services adapt to us. Most country-level respondents reported that there were no gender-responsive services at all. There is a clear, large, and unacceptable disparity in the availability of such services between the global north and the global majority as well. Even in the global north, no country demonstrated the ability to scale, and there continues to be a notable disparity between urban and rural service availability. So even before the funding cuts, these services were under-resourced and underfunded and quite reliant on donations or external grants specific to women and gender diverse people. This has only been worsened by the recent funding cuts, based on the elephant in the room. So we see also with women in particular, kind of a desire to control us and our bodies. We see pervasive prohibitionist stance presenting a key barrier to accessing harm reduction support with an overwhelming emphasis on rehabilitation and recovery service modalities, which tend to lack an evidence base. There is a lack of gender lens services for viral hepatitis prevention, testing and treatment, sexual and reproductive health, gender-based violence, chemsex, hormone replacement therapy, injecting communities, and childcare services for women and gender diverse people who use drugs. Next slide. So despite decades of progress on gender responsive harm reduction, all of those gains are at risk now. And this coincides with attacks on gender rights. It's no coincidence that, that certain folks have been elected into power in this context, because this has been coming for a long time. We've all been kind of watching in slow motion as it comes, and here it is now. We know that in low and middle income countries, harm reduction programs are already underfunded and meeting just 6% of the need. And with these cuts, we're seeing devastation. We are undermining the global fight against AIDS, tuberculosis, viral hepatitis, gender inequity, and we're also seeing huge increases in overdose deaths because of these services being canceled. So the original mission in this global mapping project has now been altered a little bit. It was previously assumed that we were marching forward, albeit slowly, and not with as many resources as we need and we deserve. But now we are recognizing that women and gender expansive people are finding that these services are just being decimated everywhere. So we're kind of right now starting to pivot and attempt to reassess what is still there right now. Rather than documenting and moving forward, we're kind of focusing on preserving what we already have instead. Next slide. So our recommendations are these. A lack of political will from leaders to address these issues is evident. More than before, governments and policymakers must be held accountable and take firm action in addressing the issues highlighted in the mapping report. High-level leadership combined with meaningful community involvement is required to uphold the health and human rights of women and gender diverse people who use drugs. There is a need for decision makers to address discrimination and stigma, to decriminalize and decarcerate women and gender expansive people who use drugs. Like Rosma was saying, oftentimes when we seek services, we get jail instead. On the very first or second day during the plenary, I forget the name of the gentleman, but he brought up some numbers on global incarceration rates for women, which were, I believe, roughly 3 times the rates for men as far as drug use. The people incarcerated for drug use, I think he said 35% women and only 11 or 12% men. Yeah, so this is definitely a gendered issue and we're being specifically targeted. And I think a big part of that is because we're vulnerable, because we have to present to care for pregnancy and for gender-related issues. and that makes us visible, and that makes us targets. There is an urgent need to preserve, defend, and expand peer-led, gender-specific harm reduction services that are safe and non-judgmental spaces, including for those with children, which is why we need childcare in our services, right? We need services for those who are currently incarcerated or recently released from prisons and jails, and for those at risk of or experiencing violence, which honestly is 100% of us. Next. So this is kind of a wish. And again, Ruth made these slides. Please let me back into the country. Don't stop me at the airport. Here is an image continuing with the elephant in the room and the need for accessible gender-responsive service fruit analogy. This is our collective aspirations for the immediate future. And what we hope for is that the tree becomes lower, that there is fruit on the ground that can be easily reached by everyone, and that the elephant is prevented from fucking with our shit. Please, next slide. Oh, never mind, that's the last one, go back. Please access the mapping at this link, or simply go on to your internet browser and search for RIN Global Mapping, and check out the services in your region and others as well. Thank you so much.
Thank you so much, Joelle. Yeah, just to say, monitoring of services, gender-responsive services is so important. I mean, action advocacy really starts with the data, and sure, this will be a fantastic resource for advocates going forward. So next, really pleased to introduce Aura, though I'm sure she doesn't need much introduction. Aura is a social anthropologist and founding director of Metzineres, Sheltered Environments for Women Who Use Drugs and Survive Violence. She's also an international advisor and great friend of people working on drug policy, harm reduction, human rights, and gender mainstreaming. And she combines research with design, implementation, monitoring, and evaluation of drug policies, programs, and services. Thank you, Aura.
Thank you, Judy. I'm so glad to be sharing this panel with these amazing and strong women that I admire, and I have so much fun with them. I also want to remember Sarah Miller-Ray, the trans woman that was killed past month here, and I want to remember her and the other trans women killed around the world, because are coming really hard times right now. And I am really glad to be here because, as you know, Metzineres has been really inspired by Colombia. If it wasn't for my experience here implementing the first programs for people who inject drugs, we wouldn't have this amazing program. I want to mention Raul Felix here. I see people from Pereira, from Cucuta. I really learned a lot from your community work. I admire that a lot. Then now I can begin. And thank you. Oh, sorry. I'm nervous now. Then, of course, I'm coming from Barcelona. You know that Barcelona for harm reduction is like a paradise. We have everything, or seems that we have everything. I have to say that with some limitations, but yeah, we have consumption rooms, we have drug check-ins, now we have shelters for people who use drugs. Also, we are really privileged because we have a feminist department. We don't know how long it's gonna take. And we have a lot of programs for women to protect women who use drugs. Anyway, protective services for people, for women surviving violence, not for women who use drugs. They are neglected from all the different networks, mental health, housing, and also from these protective services, because you are not allowed to go there if you are using drugs. The few shelters that we have that allow them bring some politics, but they still expel people. Then when they are expelled from there, they cannot have any other access, and also they don't have enough places for the 600 women at least that we see in Metzineres. They have around 75 places or something like that. Then This is why we created first the network of women who use drugs. And after a year of having coffee every week and sharing with friends and knowing that was for the first time a place where all the women could be together, not being judged and sharing their realities, and knowing that just that was really therapeutic. This was therapy. And we had the chance to open Metzineres in 2017. We become, we become a nonprofit cooperative in 2020, 3 years, crazy. And these are the values that we have. Like, as you can see, we had to think outside the box. Then we didn't ask for permit, we just opened a place. We include harm reduction services inside, and we include radical tenderness. The women in Metzineres cannot be expelled. They can throw something in our heads, and tomorrow they're gonna be welcome. The resilience is not individual, it's collective. And also the treatments, the reintegration, and all of this, we need to question if we need to go somewhere else and not in our community to take care of ourselves. We had to do that with raw courage, with activism of care, with complicity and mutual support. We are not divided between drug users and staff members, but some of us are bringing more technical knowledge, other more experiential knowledge, most of us a little bit of both, because from an intersectional feminist lens, who is a peer and who is not. No? And of course, anti-prohibition is a commitment, because if it's prohibited, we cannot do anything with that. It doesn't disappear, it just gets worse. Evidence-based, transdisciplinary, and transformative passion, because here we know that the problems and the questions is not the drugs, it's the social injustice, it's the racism, it's the sexism, the fascism, and the colonialism between others. Then, because I think that when I saw the title, we have to talk about data, I'm gonna begin for how we are collecting the data. I'm an anthropologist, but also I have been in front of different services. I know how the women have to go from one place to another, sharing their intimacy, their privacy, whatever, and have to answer a lot of questions that some are really traumatic for them. Then we decided that we didn't want any kind of questionnaire or anything like that. They can come to our place. We don't have a front desk, you will see. Then they can come, have a coffee, and if they decide that they're gonna spend 3 weeks before they will share something with us, it's okay. They can come, they can do their thing, and we're gonna go and systematize all this data really careful in a database, because we have a hacker with us that develop our database. And in that way, we can collect our own metrics, our own indicators that really answer to the reality of our community. Then the data that you're gonna see here is not from the 600 women or 500, I don't know, that we have, but from the one that really answer to that. This is really important, because we know that maybe we don't have all the data from everybody, but we know that it's real data, and also that we have more numbers in here than any of the studies that are made at the universities. Then what we see is when you take away the drugs and you don't put the drugs in the center, you can see all the complexity of their lives and all the intersectionality. All of them are surviving violence. 86% doesn't have a safe roof on their heads, and 67% are sleeping in the streets. 43% have traumatic migratory experiences. 30% are racialized. 68% are doing survival sex. 74 are facing mental health diagnosis. 43% are surviving LGBTQ phobia, among others. We wanted to collect data that also break the stigma. Then we are not collecting just data about what drugs are you having problem with, but what drugs are you using, because we know as drug users that we combine a lot of substances, no? And some days And normally when we are collecting data from the harm reduction services is, what are you using? Then this data is read that you have problem with these drugs. No? Then we wanted to be clear with that. When we are talking about gender-based violence, we are not just talking about partner violence, that also is a confusion sometimes. Then we can see that most of the women that come to Metzineres never had a life free of gender-based violence. None of the women here, none of the gender-expansive people have, but in this case, they are totally overrepresented. Also, they are overrepresented by the violence, the institutional and structural violence, because criminalization and because social and health care neglection. Then we decide to open these Metzineres, where women are totally free to decide what is their path to well-being, also trying to reduce the barriers to other services, supporting them not just in our all decision-making, they are part of the design, the implementation, the monitoring and the evaluation of all those actions, but also trying to make sure that they are part of the politics and practices that are gonna affect their lives, no? And also we want to break the stigma with the community. How we do that? This is our community hub. As you can see, it's totally informal. It's a double garage. Don't think that we have a really big building. It's a double garage where we have this social part, we have places to take care of each other and ourselves, they can sleep. Now that we are entering, the methamphetamine is with us more, is one of the biggest harm reduction tools that we have, just to have a nap in the afternoon and something to drink. This is our consumption area, because we don't define ourselves as a consumption room, but we have our spaces to consume drugs. You can snort and inject in that one. You can smoke whatever you want in the patio, and you can drink alcohol if it's your drug of choice, or benzos also if you need it. This is our right hub that is relatively new, is to face the criminalization of the women. The good thing is that they are being able to do alternative to imprison with us, which is amazing, because it's like you can do whatever you need to do. Like, okay, you are good painting nails. Okay, then this is gonna be your alternative to imprisonment. You know, like we can adapt these measures just to make sure that women can follow up with that. And I don't know if I mentioned, but I am using women, but I am talking about no men. Okay. And also the good thing is that we are able to also develop alternative measures for sanction, for fines, which is also amazing, because it's one of the main reasons why women are going to jail. We build community. We are part of the community. We are neighbors. I recommend some of the videos that we have in YouTube that you will see some of our activities that are really fun. But I wanted to present that because this is our neighbor. This is the door of our consumption room. And we prepare that, and you can see our neighbors there. The old ones, the young ones, having fun with us. They are the one preparing the paella, you know, when we cannot do it because we are really busy preparing the stage. Then, and we try to bring also the knowledge of the women and the scientific community together. And you have here some of these materials that you can use also. You can take with you, and I want to put that as an example. We were asking to the women why they were using cannabis, and we collect all the information in an informal way, having coffee, whatever. And we contact with the scientific community, in that case with ICERS, for example, Jose Carlos Bouzo, with Ana Obradors, I think that is around here, from Mujeres Canábicas, Trevor Ras, that is also there. And with all this scientific knowledge, we ask all the things that women were saying are in these scientific articles. Yes. In these 50 different articles that nobody reads because nobody can understand, and divided, and you know, and we decided to bring it here with a normal language that is accessible to everybody. and that is really useful also for everybody. Then please enjoy it. And you can look at that and all these materials online. You can support our organization. We have some tarot jets here that are really nice. And because we are in this crazy crisis, economical crisis. And this is our last project that we don't know if we're gonna be able to develop because we don't have money. But we are really close to Barcelona. If you like Barcelona, we are in the Raval, like 4 or 5 blocks from Las Ramblas. Then we decided that we need to use this space. All of you are gonna come to visit Barcelona, then come, we can have feminist, anti-prohibitionist conversation, and we're gonna try to have that in this small space. If the other local was a double garage, this is like half of a garage. But gonna be in a small store, but also we want to keep going the conversation, not just with our neighborhood, but also it's really important for us to bring all this international knowledge to our community. Then was like how we can do that. Then let's do this space, say hi when you come to Barcelona, please, and we can prepare anything, you know, we can prepare a presentation or whatever. And yeah, with all of that, we have become a model that is really easy to implement. You can see, you can do it in a double garage. Then you have, and with all of this, we have been trying to support and learn from other regions, and we have been recognized as a good practice by UNODC. And yeah, you can follow us, you can see our videos, you can get lost on that because you can see the women that are much funnier than me.
Thank you, Aura. I always love watching your presentations. They're so trippy and like, creative. But also, yeah, having been to Metzineres in Barcelona, would really encourage people to visit if they can. It is a really incredible place, I think, just full of life. And yeah, I just think a site of kind of radical love in action. That's how I think of Metzineres. And I really want to try the paella as well. So last but not least, we have Wangari Kimemia. She's an international consultant in harm reduction with 9 years experience in training, advocacy and research. Wangari currently works with RIN as Advocacy Capacity Building Project Officer for the Sexual and Reproductive Health Project. Thanks so much for your patience.
Thank you. Someone is moving for me the slides? Okay, thank you very much. So first, I would like to talk about the title, From Conception to Evaluation, Community-Led Advocacy by Women and Gender-Expansive People Who Use Drugs. So this is a project that we are still running, whereby we support community. We actually, RIN gives the little resources we have to community members in various countries, and they decide what advocacy challenges they have, and then they come up with one of the priorities as an advocacy priority, and they move with it from conception up to evaluation. And that's what I'm going to present. About the artwork that you can see, that beautiful artwork there, it is actually work done by one of the RIN's, either a woman or gender expansive person who uses drugs. And not only this one, all our artwork are developed by community members. And just to mention, this is the cover of a toolkit that we use for a 3-day training on integration of sexual and reproductive health for women and gender diverse people into harm reduction projects. Next. So, RIN, I'll not add much because already Joel has introduced RIN. It's the same organization that I'm presenting, but a different project. Our main goal is that women and gender expansive people who use drugs are able to access sexual and reproductive health services, and also to make sure that they access harm reduction also, but also removal of punitive obstacles. Now, I will be presenting about this community engagement, but I will only focus on the cascading of the results with the objective of what were we looking at? We were looking at ensuring that community members develop experiential participatory capacity. So it's just not, it is in doing that people grow. All of us where we are today is because somebody gave us a chance at 8. And what we are realizing is that advocacy in most of the countries is still being led by people who are not community with a lot of excuses. So what Rin is saying is, let communities lead from right conception, because it's normally along the way that we'll come and say, oh, Wangari, we have got this project. Are you willing to, you are given some responsibilities in the middle, but not from the beginning. We are saying community can lead right from the beginning up to evaluation. Also, we are looking at raising stakeholder awareness to health, that women and gender diverse people are facing a lot of challenges, and also we are supporting the implementation. So the next slide. So what have we, no, I'll just go straight to the countries that we have implemented this. Yeah, those are the countries where we have implemented. Over the past 2.5 years, we have implemented in 9 countries, and right now we are implementing in 3 countries. And when we look at what has come out from this, or how we are doing it, first let me go to the methodology. So we usually come up, first we have group discussions, 2 group discussions per country. Usually they are not led by RIN, no. It's a community member who is picked from that country. We call that person a national focal person who is a community member also. They're the ones who do everything. We do it community-led, 100%. And then we usually include people who were in the workshop. Remember, we start with a workshop and then now we go to the group discussions. Why are we including people who are in the workshop? Because the workshop is about creating, sensitizing people on what is missing. Are women and gender diverse people able to access things like, simple things like menstrual pads? Are they able to access things like, and the main challenges we will see is actually accessing perinatal care when women and gender diverse people are pregnant. So we usually include someone who was in the workshop, and then they will discuss and come up with consensus. They'll agree, yes, we have so many challenges, but which one do we want to run with? Because resources are limited, of course. Then they plan themselves, and then you will see. The next one, there is an eye. We love this eye very much. No, there's somewhere there's an eye. Next. Thank you. Yes, the same eye. So I'll not explain about its meaning, but I would like us to look at the various priorities that we have come up. This is really what has been an eye-opener for us. For every country, for every of the 12 countries where we have implemented this project, stigma and discrimination in the hands of healthcare workers is cross-cutting. It's hard sometimes to come up with, to decide what to advocate on because there are so many challenges, but every country, the main challenge has been stigma and discrimination by healthcare providers. And the question we ask ourselves is, yes, we are doing so much, but until when will people not be able to access services just because they used a drug? The other things, I will not discuss all of them, but specifically I will single out perinatal care. I will single out perinatal care because the exaggerations, the scare that people when they are pregnant are taken through, you know, a lot of things that are said that do not have any basis, that are not true. And I would really want to call upon all of us here, please, in our various countries. I think this is one of them, and I really appreciate Joelle because she has been our teacher in this. Please, let's really address this issue of people, women and gender diverse people who use drugs and pregnancy. There is too much exaggeration, and I call upon you, we have resources. You can go on RIN page, you will find the toolkit, and of course, Joelle, you can look at what has been done by the academic of perinatal harm reduction, just debunking these myths. let's talk about specific drugs. Let's not say drugs in general. We're not talking about alcohol. I'm not saying there's anything wrong with alcohol, but we only go to the criminalized drugs and create a lot of problems. And this is what is one of the main challenges. And I think it has also been mentioned by the other speakers as a main challenge because of one of the speakers said, when a woman is pregnant, instead of listening to her, you want to take her to treatment. She did not ask for treatment. So what have we done? The next slide is about what we've done. I will not go into the details, but it has really been a very interesting project. If you'd be interested with finding out what we've done, and if you would be interested in this project in your country, please, you can talk to us after this, or you can even join us tomorrow. We have a meeting actually in room 2D. If you can join us in room 2D during lunch hour, we'll be discussing more about the various challenges and the various impacts of the current pushback. So we have had 24 community group discussions. We've had 74 community actions in only 12 countries. And we've reached 70 decision makers. And I will not go into the details, but I can only speak about 3 countries. That is Kenya, Indonesia, and Burundi. The next slide, please. Yes, this is the beautiful work done by our community members in the 3 countries, particularly Indonesia. It was really, we had a talk show. And after the talk show by the women and gender diverse people who use drugs, they have reported that in West Java, there's more responsive towards providing sexual and reproductive health for women, especially cervical cancer screening for women and gender diverse people who use drugs. In Kenya, where I come from, we had a meeting with the judicial service providers, because in Kenya there's a lot of GBV, and we've seen that now women who use drugs and gender diverse people who use drugs are able to speak with the court users committees. They've been able to become part of the system. And finally, about Burundi. Burundi was looking at access to menstrual pads. You see, it may be those small things that we may not take like it's a big deal, but how do you expect a woman who uses drugs to come for harm reduction services, or a gender diverse person who has their menstruation to come for harm reduction services when they're on their menstruation and they cannot even afford the materials? I mean, it's those small things that don't even cost a lot of money that we are asking that we look at. And as I come towards the end, I'll be looking at the recommendations and say, there's a big gap in community-led advocacy for women and gender expansive people who use drugs. They are still kept in the periphery. People who are not community still want to lead advocacy, and we all know about 30, 80, 60. Countries, we know about 30, 60, 80, 30, 80, 60, but we seem like it's business as usual. It cannot be business as usual. Community need to lead in the 30, 80, 60 because it can be done. Furthermore, only half of all country focal points were able to secure engagement with gender expansive people who use drugs. This is a major gap. Because even for us, where we are asking, let everyone be in the groups, you'll find most of the groups will be only women who use drugs. Gender diverse people who use drugs are left out. And yet they are there and they are willing to be present. So this is another challenge that we are asking. When we talk about, let's not leave anyone behind again, let's have everyone included. Now, the comment we found that kept coming up, most of our focal people was, this is the first time I have been involved in advocacy. So advocacy is happening, but community is not being involved. And even if it's being involved, it is not from conception to evaluation. It's somewhere in the middle, tokenism kind of a thing. And this will not give us the results that we would get if community leads. Now, criminalization of drugs is gendered in practice, actually, acting as a major barrier for women and gender diverse people who use drugs. Now, in the backdrop of the limited resources, we all know that resources are becoming more and more limited. And actually, in the current situation, it becomes even more critical to defend this approach, where community lead, because the resources are meager, we can't afford to waste them on processes and bureaucracy that can be escaped. Now, if your program would be the last slide, please, as I add. Yes. If you would like more details about Irene, if you would like to find out more, feel free to go to our website. There are so many resources. We can't present them even if we had a whole week. It's a network. So please go there, find out more resources, reach out to us. We can share more resources. And most importantly, please join us tomorrow at 1 p.m. in room 2D. Thank you.
Thank you so much, Wangari. So we still have, because we started late, probably about 15 minutes for questions. There was one question submitted via our online platform, so I'll just start with that before I move to the room. And this is for anyone that would like to answer on the panel. How would you suggest that we promote SRH services amongst women who use drugs within harm reduction programs? How should we promote sexual reproductive health services?
So some of this stuff we talked about already. Yeah, please take it. Firstly, I think hiring women and people with children specifically, and making workplaces that are that people who have children can work in. So many nonprofit organizations in harm reduction, at least in my experience in the global north, tend to focus on hiring young single people without children. They don't provide childcare, they don't provide health insurance for dependents. So we need to start putting people who have children in these places. We need to start promoting childcare. And for example, I've talked to a lot of women who are unable to access a pap smear or who are unable to access counseling because you can't have a counseling session with your 3-year-old in the room, right? It's not possible. So we need to have services that come with the expectation that people have children that they have to take care of and provide spaces that are safe for those children. So that's just a start.
I will add that, of course, the beginning is to have a safe place where women and gender non-conforming people can go, and also to adapt to the different periods of our life, no? Because, of course, now that we have an old population in Europe, menopause is important, no? We have a lot of young women, trans women, that are really confused with what kind of hormones, and they are getting educated about transformative gender because they are learning in the streets outside any medical advice. Then I think that just to have a safe place where you can have honest conversations, doesn't matter your age, and also attending all the gender expansive people is really important.
Just briefly, because we won't have so much time. Tomorrow, several of the speakers will also have a session that is more a workshop and a conversation, because I'm sure there is so much knowledge and intelligence in the room and we don't have so much time. So if we want more to have a conversation about this exact topic tomorrow, please come to the session as well. And just on this topic, I was mentioning International Planned Parenthood has 150 organizations across the world. Many of them do not work with women who use drugs. They do not work with sex workers. They might not work with trans women, etc. But I feel like the main issue is the stigma associated with drug use and sex work, etc. And one of the things we're going to do this year is developing with the global network of sex work projects a value clarification tool, which will be a training for service providers to understand their own bias, so specifically on sex work, but for them to understand why do you treat sex workers this way? What is built in your consciousness that you think you can talk to people the way you are talking? And that's an issue that is across the world, including in IPPF and our members and service providers. So it's also possibly something we could collaborate on with Women Use Drugs Network and to address stigma in services.
Hi, everyone. I'm Michelle Ouazan. I'm from Lebanon. Thank you so much for all of the presentations. So I have a question. So we operate a service that is inclusive of women in Lebanon. Substance use and being queer are both criminalized. So if one of our successful approaches was to integrate our services within public health care setting or primary health care to kind of hide, in a sense, that it's a substance use service. So what is the compromise you make if you're creating a service that is only for women and gender diverse people, between visibility and exclusivity in the sense of it? This is just for specific people. I don't know if that was clear, but.
I think that you have to adapt to your context, you know, and for us also, where you can be really open about your drug use in Barcelona, relatively, we were able to do a really transparent place, and it helped a lot with the community, because the community doesn't feel that this is a consumption room where they don't know what is going on inside. They can see that it's a community, they can see the workshop, they don't see what is going on in the back, but they can enter, have a coffee with us. It's a really transparent way. It helped a lot with the community. But I understand that you cannot do that in most of the places where the stigma is so fucked up. Then if you have any service that allows you to be what you need to do, go for it. And also, but I want to say something about visibility. And I think that sometimes we are asking a lot for the women to be visible on that, not paying attention of the consequences. And I find that a lot with documentaries or people that want to do interviews, et cetera, coming to workplaces and not informing well to the young women, especially, what can be the consequences to be visible in a long term. And I know that here there are a lot of researchers, there are a lot of people. Please, if you do this work, please inform, make sure that the other person understands the risk of being visible. Because, yeah.
I can't really speak to what it's like in Lebanon, being from the United States, but I think you can use code words. You can say, we distribute insulin needles or something like that. And also use your natural networks that exist. Know people who use drugs and have the word spread that way rather than advertising a lot. But it's a really hard question without easy answers. And please come take some resources we have on the tables up here. Tenemos en inglés y español.